Diverticulosis is the condition of having diverticula or outpouchings. Many patients are asymptomatic and have no idea they have the condition. The outpouching can be compared to a protrusion or herniation. The incidence increases with age, with diverticulitis found in 30 to 50% of adults over the age of 60 and increasing to 65% by age 85. Men are more affected than women in younger patients, whereas females are more affected in older patients. It is also important to note that younger people can get this condition as well. Risk factors for diverticulosis include increasing age, obesity, smoking, low fiber diet, heredity, and some medications such as NSAIDs, acetaminophen, oral corticosteroids, and opiates. There has also been an association between eating red meat and high-fat diets with the risk of diverticular complications. When diverticula become inflamed, the condition becomes diverticulitis. It often occurs in the sigmoid colon. When a patient has diverticula, the colon wall thickens and becomes rigid. Without adequate fiber intake, more water is absorbed from the stool. This slows transit time and makes it more difficult for the stool to pass through the colon. This then causes increased intraluminal pressure from constipation and straining, which is thought to lead to the formation of diverticula. Dietary fiber is thought to act by producing a larger, bulkier stool that results in a wider bore colon, which is less likely to develop diverticula. Food can become entrapped in the diverticula, and when it mixes with normal bacterial flora, this leads to decreased blood supply, forming a mass called a fecalith, or dried, hard, concrete-like stool. The diverticular wall is eroded by increased intraluminal pressure or hard, dry food particles. This process leads to inflammation and/or infection. The inflammation can spread to other areas of the intestine, and because the sigmoid colon is the segment with the smallest diameter, increased intraluminal pressure may predispose this area to more frequent herniation. Diverticulitis may be acute or chronic. In chronic diverticulitis, the bowel can become scarred, leading to narrowing of the lumen, and the patient may develop an intestinal obstruction. In a small number of patients with diverticulitis, it is difficult to distinguish from carcinoma because both may show focal thickening of the bowel wall, or it may even resemble inflammatory bowel disease. Diverticulitis may lead to stricture formation that also has the appearance of cancer, so biopsy is required to make the differential diagnosis. For this picture, just note that the outpouchings are in the descending colon and the sigmoid colon, both which reside on the left side of the body. If you look at the picture on the right, it's showing you some that are inflamed, and once it's inflamed, it becomes diverticulitis. This picture is someone's colon. Look where the two arrows are, and you can see it kind of looks like a little tunnel, but that's the actual outpouching. Patients with diverticulitis complain of abdominal pain over the area that is involved, usually the sigmoid colon, and remember that's the left lower quadrant. They may experience fever or leukocytosis, and often a palpable mass is felt over the involved area. The patient may complain of increased flatus, anorexia, abdominal bloating or distension, and diarrhea or constipation. Stools may contain mucus and blood. Bleeding occurs because of inflammation near areas of blood vessels and may range from minor to severe. Now, older patients are going to be different. They may present afebrile and have a normal white blood cell count. They might also have minimal abdominal tenderness. The first sign that may appear in the older patient is a change in mental status. So just like if they had a UTI, that might be the only sign that we have. Baseline temperature is often decreased from normal in the older patient as well. Therefore, one of the most common signs of infection may not be apparent in the older adult, and the patient may present with increased confusion, falling, and anorexia. If perforation has occurred, the patient may present with clinical manifestations of sepsis. If the pain is more generalized over the abdomen, peritonitis may have developed, and if peritonitis has occurred, the patient displays profound guarding with widespread rebound tenderness. For symptoms, we can think of the acronym WHAT's UP. Where is the pain? Usually is going to be the left lower quadrant. How does it feel? We want to know the quality of it. It's usually tender and cramping. Are there any aggravating or alleviating factors? Constipation and a low fiber diet may aggravate it. Treatment of constipation may alleviate it. For timing, was it a gradual onset, intermittent? Severity is usually between 5 and 7. Other useful data could be intermittent rectal bleeding, straining at stool, constipation alternated with diarrhea. They might even have pus in the stool or blood in the stool. And then the patient's perception, they usually fear a diagnosis of cancer. Now we want to know how it's diagnosed. Many times an abdominal x-ray is performed, but the diagnosis is usually confirmed with a CT scan. The CT scan also helps differentiate from other sources of abdominal pain and complicated cases of diverticulitis. White blood cells are monitored for elevations initially associated with inflammation and possible infection, but should decrease with treatment. A urinalysis may show a few red blood cells if the ureter is near a perforated diverticulum. The patient with suspected diverticulitis should not have a barium enema because of the risk of rupturing the diverticula during testing. Uncomplicated diverticulitis may be treated on an outpatient basis with broad-spectrum antibiotics for 7 to 10 days, but should be reassessed after 2 to 3 days of therapy. The patient is advised to consume a clear liquid diet until symptoms subside, and then they can advance slowly as tolerated. Common antibiotics could be ciprofloxacin and metronidazole, Bactrim, Augmentin, or moxifloxacin. The patient should be admitted to the hospital for fever over 102.5, microperforation, immunosuppression, significant leukocytosis, severe abdominal pain or diffuse peritonitis, advanced age, significant comorbidities, intolerance of oral intake, noncompliance, or they were treated outpatient and it failed. There are no dietary restrictions in acute uncomplicated diverticulitis, although limiting to a clear liquid diet for 2 to 3 days is common while advancing is tolerated. If the patient is admitted to the hospital, IV fluids are started and nothing is given by mouth to allow the bowel to rest. The patient may have a nasogastric tube for bowel decompression and will receive parenteral antibiotics. Laxatives and enemas should be avoided because they increase intestinal motility. Pain medications may be given as needed, and opiates are frequently needed. Inpatients may be discharged as clinical manifestations resolve and should complete a course of 10 to 14 days of antibiotics and then have a follow-up exam. After clinical manifestations completely resolve, the patient is recommended to have a colonoscopy to assess the extent of the diverticular disease. For colonoscopy, there are a few options for the bowel prep, but the patient is usually placed on clear liquids the day before and begin bowel prep the evening before. They will be NPO after midnight and must have someone drive them home after the procedure due to anesthesia given. Failure of medical management may necessitate the need for surgical intervention. Indications for surgery may include perforation, obstruction, abscess formation, which is not responding to antibiotic treatment, or fistula formation between the colon and another pelvic organ. If the patient develops complications, they may require surgery to remove the diseased portion of the colon. They may have a temporary colostomy because re-anastomosis 3 to 6 months later is usually successful. Complications include perforation, microperforation, abscess and fistula formation, bowel obstruction, and bleeding. Inflammation can also result in fistulas to other organs. Fever often accompanies diverticulitis, ranging from a low-grade fever to 101 degrees Fahrenheit due to inflammation. Tachycardia often accompanies increased temperature. Pain accompanies diverticulitis, usually in the left lower quadrant or mid-abdomen, depending on what area of the colon is involved. If abdominal pain is generalized, the diverticulum may have ruptured, and peritonitis should be suspected. Altered bowel habits often accompany diverticulitis with constipation, diarrhea, or both. The patient may also complain of increased flatus and anorexia. Elevated white blood cells are indicative of infection. However, it is not unusual for the patient with diverticulitis to initially present with a normal white blood cell count. Nursing diagnoses include acute pain related to inflammation and distension of the colon, and knowledge deficit related to the need to consume adequate fiber in the diet. For vital signs, we're looking at fever, which could be low grade, and then tachycardia. Serum potassium, we want to monitor that because the patient may be on intermittent NG suction and they may require replenishment. Fluid volume status can be impacted by NG suction and decreased intake, so we need to monitor their urinary output to make sure that renal perfusion is intact. Pain, we know, is going to be the left lower quadrant. It could also be mid-abdomen, depending on the area that's involved, or if we're concerned about peritonitis. And then mental status changes in older adults. We know this already, okay? That's usually the symptom that's prevalent. Administer IV fluids because patients are often NPO during the acute phase to allow for bowel rest. Administer ordered antibiotics because diverticulitis is a localized infection. Antibiotics are administered until pain, inflammation, infection, and fever subside. If a nasogastric tube is present, it's usually to low intermittent suction for gastric decompression. It also decreases gastric motility and allows the bowel to rest until inflammation decreases. And then don't forget about providing oral care. The oral cavity might be dry due to insensible fluid loss, but the patient might also be mouth breathing due to the NG tube, so don't be afraid to apply lip balm to any dry, cracked lips. The patient needs to be on low fiber diet in the acute phase, but once the diverticulitis has resolved, then they need to have a high fiber diet because remember, one of the risk factors was not having enough fiber in their diet beforehand. Avoid straining, bending, and lifting because those activities increase intra-abdominal pressure, which can lead to further outpouching of the diverticulum. Obesity is one of the risk factors, so we want the patient to try to lose weight because obesity also increases the intra-abdominal pressure. And then adherence to antibiotic therapy is important, so the nurse should stress to the patient that they need to finish the medication as prescribed. Okay, for evaluation, we want the patient to be free from abdominal pain and free from fever, but we also need to make sure that they understand that they need to have adequate fiber intake from here on out. BPH stands for benign prostatic hyperplasia. Another name that you might see is hypertrophy, which just means enlargement of the prostate gland. The prostate gland is a normal part of the male anatomy and is about the size of a walnut. It also surrounds the urethra. Its primary function is to assist in controlling urine flow. It also mixes sperm with prostatic and seminal fluid to be ejaculated during orgasm. For reasons unknown, the prostate begins to grow around age 25, but there's increased incidence as the person ages, usually over 50. There are theories that include a balance change between estrogen and testosterone, an accumulation of the male hormone DHT, or a high intake of calories, protein, calcium, and polyunsaturated fats. A patient can have BPH and prostate cancer simultaneously or independently of each other. The clinical manifestations of BPH are related to lower urinary tract symptoms that include difficulty starting the flow of urine even with straining, a weak stream of urine, multiple interruptions during urination, and dribbling once urination is complete. Symptoms related to changes in the bladder include urgency, frequency, the feeling that the bladder has not completely emptied after urination, and frequent awakening at night to urinate. As the bladder becomes more sensitive to the retention of urine, incontinence may result. The patient may experience bedwetting and the inability to respond quickly enough to the need to urinate. A urethral obstruction or enlarged prostate that is left untreated may result in bladder outlet obstruction, which includes acute urinary retention, bladder infection, bladder stones, and increasing pressure in the kidney, which could possibly result in hydronephrosis or post-renal acute kidney injury or pyelonephritis. Diagnosis is made on the basis of symptoms and is confirmed with a digital rectal exam because the enlarged prostate can be palpated on examination. A urinalysis is also done to rule out the presence of an infection causing any of the symptoms. In addition, the prostate-specific antigen level is checked. This is a protein produced by the prostate gland and may be considered a tumor marker because an elevated PSA may be indicative of prostate cancer. But it's important to note that raised PSA levels might be due to infection, so it does not mean that the patient has cancer. The least invasive treatment for BPH is watchful waiting or active surveillance. This approach is used in patients who have minimal symptoms and minimal enlargement of the prostate. Patients who opt for this treatment plan receive yearly provider examinations with evaluation using a DRE. It is advised during this watchful waiting period that the patient avoid tranquilizers and over-the-counter medications that contain decongestants because these medications can worsen obstructive symptoms. In addition, patients should avoid excess fluids in the evening to decrease the chances of nocturia. Looking at this chart, you can see that the patient can have mild all the way to severe symptoms, but as long as it's not interfering with daily life, then watchful waiting is okay. As soon as symptoms interfere with daily life, then the patient needs to discuss with the doctor, maybe starting some medication or looking into surgery options. If they have obstructive symptoms, then that patient usually is going to need surgery. There are a few options of medications that'll work. Alpha adrenergic blockers act on the alpha receptors in the prostate, causing the smooth muscles of the prostate to relax. Relaxation of the muscles decreases the constriction of the urethra. It may take 2 weeks to 4 months to notice symptom improvement. The patient needs to be aware of adverse effects such as headache, nasal congestion, dizziness, drowsiness, postural hypotension, reflex tachycardia, and retrograde or delayed ejaculation. An example of this type of medication would be Flomax or tamsulosin. Another medication classification is the 5-alpha reductase inhibitors, which act as anti-androgens. Testosterone affects prostate growth and development. 5-alpha reductase converts testosterone into DHT or dihydrotestosterone. Dihydrotestosterone stimulates the growth factors that encourage prostate hyperplasia while concurrently reducing the rate of cell death in the prostate. This imbalance results in enlargement of the prostate. The 5-alpha reductase inhibitors prevent testosterone from being converted to DHT, which causes enlarged tissues to shrink, thus reducing obstruction of the urethra. Another positive of this medicine is that it doesn't affect circulating testosterone, so it decreases the chance of erectile dysfunction. It can take 3 to 6 months for these meds to take effect. It has been reported that some men may experience a reduction in male pattern baldness. Possible adverse effects include rash, breast enlargement, breast tenderness, reduced volume of ejaculate, decreased libido, and ED. Some men experience better results with a combination of the alpha blockers and the 5-alpha reductase inhibitors. The combination has been shown to delay clinical progression as much as 67%. An example of a 5-alpha reductase inhibitor is the medication Proscar or finasteride. If the patient with BPH has an overactive bladder, an anticholinergic to relax bladder smooth muscle, such as oxybutynin, may be added. If pharmacological treatment was not effective and the patient is a surgical candidate, then one of the most common surgeries for BPH is a transurethral resection of the prostate, or TURP. It is usually used to treat smaller prostates. In the procedure, a lighted scope, known as a resectoscope, is passed into the urethra. A small cutting tool is used to remove the entire inner prostate, leaving the outer layer. Symptoms are usually relieved quickly, resulting in a stronger flow of urine. A catheter may remain in place after surgery for 3 to 5 days to drain the bladder. Recovery from a TURP may include a risk of bleeding and infection. The patient is permitted only light activity immediately postoperatively. Another procedure is the transurethral incision of the prostate and is used for a patient with small to moderately enlarged prostates. During this procedure, instruments are inserted through the urethra just like the TURP, but the prostate is not removed. The surgeon makes 2 small incisions into the prostate, which relieves compression of the urethra and opens up the channel. The result is an easier passage of urine. For a patient with a very large prostate who is experiencing complications such as bladder stones or bladder damage, the surgeon may perform an open prostatectomy. This procedure is performed approximately 200,000 times a year in the U.S. During this procedure, an incision is made in the patient's lower abdomen to access and remove the prostate gland. It carries a higher risk of complications such as incontinence, impotence, and retrograde ejaculation. Another option is laser surgery for men with smaller or moderately large prostate glands. This therapy uses high-energy lasers to annihilate and/or remove overgrown prostate tissue. Several laser procedures include ablation procedures that burn away prostate tissue and enucleation procedures that remove the prostate tissue that is restricting the flow of urine and prevent tissue regrowth. Laser surgery usually results in immediate symptom relief and has a lower risk of adverse effects than a TURP. This may be used for men who are taking anticoagulants because there's usually less bleeding. I mentioned that a patient may have a catheter in place for a couple of days. One reason is the doctor may order continuous bladder irrigation, and the goal is to maintain the flow rate of the irrigant to keep the output light pink or colorless. We need to assess urinary output every 1 to 2 hours for color, consistency of amount, and presence of any blood clots. Also assess for bladder spasms, pain, and bladder distension. Bladder distension may result from output obstruction, which increases the risk for bleeding. Make sure to calculate the difference between irrigation fluid and the patient's actual output when calculating I&Os. There's something else that we need to watch for called TURP syndrome. So we need to assess for fluid volume excess and hyponatremia in addition to decreased hematocrit, hypertension, bradycardia, nausea, and confusion. If any of these occur, notify the healthcare provider. TURP syndrome results from the absorption of irrigating fluids during and after surgery. If untreated, it may result in dysrhythmias and/or seizures. This chart shows you complications of BPH. It could be as simple as urinary retention, UTI, or bladder stones, but I mentioned a couple of other things such as hydronephrosis and pyelonephritis. Hydronephrosis is when the urine backflows. Instead of going from the ureter down to the bladder, some of it will backflow towards the kidney and can cause infection. Pyelonephritis is a UTI that migrated from the bladder to the kidney. Urinary symptoms are of concern if it's affecting their daily life. We should still document information about it. Temperature, we're looking at to see if it's elevated, they might have a UTI. A distended abdomen may signify bladder distension, so the patient might not be able to empty the bladder all the way and would be at a risk for UTI. A bladder scanner could be used to see if there's any post-void residual, indicating that the patient has urinary stasis that could lead to infection. And then a urinalysis can be checked to see if there's infection. Intermittent catheterization can be used to relieve the bladder of any post-void residual that's left over, to relieve that distended bladder and then decrease risk of bladder damage. And then we would administer any medications if they're ordered. It is important to teach about each of these. However, I would say stress the importance of follow up with the provider to report any worsening symptoms and need for possible further intervention. If they discuss any surgical options, then printed information may be helpful for that. And then if there are any surgical or treatment sites, then teach the patient about aseptic technique to decrease the risk of infection.